With this, we move on to the next session of today's scientific feast. So it will be on seizure disorder in diabetes. And the speaker for this particular session is Dr. Arindam Ghosh. He is the clinical lead neurology, Narayana Super Speciality Hospital. He is a consultant neurologist at R.N. Tagore Hospital, Sri Aurobindo Seva Kendra. He is a co-investigator at multiple trials and multiple lecture and preculations he already has. And at national and international conferences, he had presented several times. And to chair this particular session, I would like to invite Dr. S.K. Somani. He's a very senior neurologist with more than 42 years of expertise, founder member and member of scientific affairs of Howrah Town Diabetes Study Society. Along with him, I would also like to invite Dr. Niloy Biswas, experienced consultant neurosurgeon at Narayana Super Speciality Hospital. I welcome both the chairpersons and I would request you to kindly introduce our speaker today.
So this session is on seizure disorder in diabetes, and the speaker is our learned colleague, Dr. Arindam Ghosh. Dr. Ghosh, please.
Thank you, Chairperson. At the outset, let me take this opportunity to thank the organizers for giving me an opportunity to address all of you. I think we need to set the timer. Yep, okay, good, great. So I've missed the chance to speak at the HDS conference on 2 occasions because I was traveling, and for many years, Mridulda was very upset because I was not here. So this time when he gave me an opportunity, I said I will not miss this. And of course, we know diabetes is responsible for a variety of neurological problems, cerebrovascular diseases, vascular dementias, peripheral neuropathy, restless leg syndrome, autonomic neuropathy, so on. But what could a diabetic patient have to do with seizures? This was an interesting topic, and I thought while looking this up, I learned quite a bit myself. So here goes. A quick outline for my talk. I'll be speaking on the epidemiological data first, a little bit on the prevalence studies and risk factors, the pathophysiological basis of concurrence of 2 very vastly different ailments, the common pathways of mechanisms of interaction, effect of one on the other, and of course the shared risk factors, therapeutic implications, and if I have time, a little bit on the special situations. So it is a strange partnership. One is a hypersynchronous discharge from a group of CNS neurons. The other is a metabolic disorder because of a lack of insulin. So what is common in these? Epilepsy afflicts about 50 million people globally, whereas diabetes is way more vast and affects more than 500 million people. This is data of 2022. There's an intricate relationship despite the fact that they have an apparent dissimilarity. And the concurrence of both disorders is important because we need to remember there are clinical manifestations, economic and public health ramifications secondary to both of these existing together. Also, a patient afflicted with both is likely to use healthcare resources more, is likely to have more escalated costs, economic costs related to his health burden, and also because of epilepsy, depression, diabetes, also vascular cognitive impairment, perhaps a reduced ability to carry out activities of daily living and daily tasks. Let's look a little bit at the prevalence studies as to what we have. Between 1995 and 1998, this is a very interesting study carried out by Josimir Sanders' group in the United Kingdom. And they looked at patients who were afflicted with diabetes and a whole host of other comorbid illnesses from neurological to metabolic, including diabetes. They found that patients who were epileptic above the age of 64 years, diabetes was more common in epileptics as compared to normal healthy controls. In men, slightly more, but in women, it was vastly different. 10% of epileptics had diabetes, whereas 6% of the non-epileptics above the age of 64 had diabetes. In younger populations between 16 and 64 years, this was even more stark. Epileptics had a greater incidence of diabetes, 2.8 to 1.8 for men and 2.5 to 1.4 for women. So there is certainly a correlation between epilepsy and diabetes as per this prevalence study, which was carried out in over 20,000 people. I always like quoting studies closer to home, like Southeast Asia, India, and these places because of racial similarities. And this is a Taiwanese study by Chung-Yi Lee. And this study notes that there is a significant association between diabetes and hypoglycemia with epilepsy. They found that in a 10-year follow-up of patients with type 2 diabetes mellitus, the incidence rate of epilepsy was far more than controls who did not have diabetes, 35 to 22 per 10,000 person years. And when you remove the confounding factors, both type 2 diabetes mellitus and hypoglycemia were independent risk factors for epilepsy. Another Chinese study by Chen Yun looks at the fact that 25% diabetic patients over their lifetime have a risk of epilepsy. So how common is epilepsy in diabetics? Of course, we know there's a higher risk of seizures. The risk is 1.5 to 2 times higher than the general population. Type 1 diabetics are even greater at risk. It's almost a 3 times greater risk than the general population. Advanced age is a risk factor, importantly because there's a combination of vascular and metabolic variables, and also age-related changes in brain function and structure, which includes microvascular cerebral lesions and permeable or leaky blood-brain barrier. This is a nice population-based study from the United Kingdom, which looks at the fact that type 1 diabetes mellitus is present in epileptic patients. This is a population-based, cohort-based study, which looks at about 25,000 people. 5,000 had type 1 diabetes, and about 20,000 were controls, healthy controls. Type 1 diabetics were 3 times more likely, so 132 to 44 per 1 lakh patient years, in compared to controls, to develop epilepsy over their lifetime. Let's look at some of the risk factors, epidemiological risk factors. Age, advancing age because of alterations in brain structure and function. Women are more likely to be afflicted than men with both diabetes and epilepsy, simply because there is an underlying autoimmune condition like GAD65. Well, autoimmunity seems to be more common in women than in men, and that's why the concurrence of both seizures and diabetes. Lower socioeconomic strata seems to be more affected, and for geographical locations, rural populations seem to be more afflicted and suffer the effects of both these diseases if they coexist, simply because of lack of awareness and access to health care. So what's the pathophysiological basis of both these diseases coexisting? As I said, these are very different conditions. So what's the shared etiopathogenetic mechanisms? There are hereditary propensities, shared inflammatory mechanisms, and metabolic dysfunction, one worsening the other. The precise etiology is still unknown, but several hypotheses have been postulated, and that includes oxidative stress, cytokine-mediated immune abnormalities, microvascular lesions in the brain, a leaky blood-brain barrier, metabolic factors, and of course genetic mutations. And it's important to identify these risk factors because we need to implement timely intervention strategies which may prove advantageous for both conditions if they coexist. Let's look at reactive oxygen species, oxidative stress, and metabolic dysfunction secondary to mitochondrial ATP loss. First up, if there is an increase in reactive oxygen species, that results in oxidative stress. I can't see the cursor. Can anybody see the cursor? No. Well, I would like to show them with the cursor. Okay, increased reactive oxygen species will result in oxidative stress on the right, if you can see. That would tip the balance in favor of pro-inflammatory cytokines. There would be inflammation, followed by epilepsy. Also, increased reactive oxygen species impairs calcium ion homeostasis, hyperexcitability, and that leads to epilepsy as well. Also, if there's a decrease in mitochondrial ATP on the left, if you see the left flow charts, you would notice an alteration of neurotransmitters, increased glutamate and excessive consumption of GABA. So the GABA levels drop. That could result in hyperexcitability and epilepsy. On the other hand, if there's impaired blood-brain barrier, that could result in neuroinflammation, neurodegeneration, and epilepsy. And finally, impairment of the ional channels, both sodium and potassium, could result in depolarization, and that could result in hyperexcitability, neuronal firing, and epilepsy. So all of these conditions could result in an epileptic seizure in patients with diabetes. What about inflammation and pro-inflammatory cytokines? Both of these, and it's being increasingly recognized that epilepsy is an inflammatory condition. The inflammation is at the glial cells for epileptics. And once these glial cells are activated, there is a release of pro-inflammatory cytokines like TNF-alpha, like IL-1 beta, like other cytokines that can result in an inflammatory change, worsening epilepsy. Also, in diabetes, if there's a hyperglycemic condition, insulin resistance can sometimes set in, and that can cause inflammation, resulting in release of pro-inflammatory cytokines like TNF-alpha, IL-6, and IL-1 beta. Let's look a little at the metabolic dysfunction leading to neuronal injury. So if you have hyperglycemia, there's oxidative stress, there's activation of the sorbitol pathway. And both of these, hyperglycemia and activation of the sorbitol pathway, causes significant oxidative stress and macromolecule glycation. All of these together result in MAP kinase activation. This in turn results in post-translational modification, affecting different parts of the neuron, including the astrocytes, the microglia, and other parts of the Schwann cells as well. So that could result in neuroinflammation and epilepsy. What about the mechanisms of action? We need to know how seizures affect glucose metabolism and glycemic management, and also are there possible shared etiopathogenetic risk factors causing both to coexist? How am I doing with the time? Okay, 15 and a half minutes. So the effect of seizures on glucose metabolism. Seizures, you know, are a dynamic process, and they increase the production of stress hormones like cortisol and adrenaline. This causes impaired insulin, impaired absorption of peripheral, the ability of the peripheral tissues to absorb glucose as a result of insulin resistance. Also, epileptic seizures affect the autonomic nervous system. We were having a talk with diabetes and dysautonomia with Dr. Ramesh Bhattacharya yesterday. And epilepsy also can affect the autonomic nervous system, causes a change in the heart rate, blood pressure, and that can result in impaired insulin secretion and sensitivity, which further compromises glycemic control. Neurotransmitters can also be affected, so that could impact both nutritional preferences and hunger control, particularly the serotonergic raphe nucleus, and that can worsen glycemic instability because of abnormal or aberrant food habits, excessive food intake, and macronutrient composition. Be careful about some of your anti-epileptic drugs. Sodium valproate and phenytoin can affect insulin sensitivity and glucose metabolism, therefore causing hyperglycemia and obesity. And there are certain situations where there is acute glucose dysregulation during and after a seizure. I will discuss this a little later. I also wanted to highlight the interesting relationship that exists between epilepsy, diabetes, and psychiatric comorbidities, including depression and anxiety. Multiple studies have suggested that these are coexisting factors, one worsens the other. So with seizures and depression, in the background history of diabetes, there's increased accumulation of ILB at the hippocampus. That dysregulates the hypothalamic pituitary adrenal axis, and further, that results in impaction on the serotonergic raphe nucleus in the hippocampus, resulting in altered levels of serotonin secretion, which in turn may affect the hunger pangs, cause people to eat more, and impact glycemic control. How is diabetes' effect on epilepsy? I was just discussing a little while ago that there is increased brain excitability and oxidative stress. There's increased neuronal excitability and synaptic transmission. All of these are because of diabetes itself. This is an interesting article by Paula Schauecker looking at the effects of glycemic control on seizures and seizure-induced excitatory cell death. Also, as I was mentioning, oxidative stress, hyperglycemia itself can lower seizure thresholds, making people more prone to seizures. Also in hyperglycemic conditions where there's insulin resistance and inflammation, there is release of pro-inflammatory cytokines like TNF-alpha, IL-6, and IL-1 beta in diabetic patients. Keep a watch on the oral hypoglycemic agents that you're using. For instance, metformin has been known to modify mitochondrial activity and oxidative stress, and therefore may be somewhat protective in preventing a seizure. On the other hand, sulfonylureas may result in inadvertent hypoglycemia and can precipitate a seizure. So you need to be careful. Also, depending on what kind of anti-epileptic drug you're using because of drug and drug interaction. Let's look at some of the shared risk factors. I'll talk about genetic, environmental, lifestyle, and psychiatric comorbidities. There are several susceptibility genes, and if you're interested in epilepsy-associated genes, this is a rather interesting article by Ji Wang, which looks at all of the susceptibility genes with epilepsy, not just with epilepsy and neurological conditions, but with metabolic factors as well, including thyroid diseases and diabetes. But the interesting genes that I wanted to point out was KCNJ11 and ABCC8 genes, which have both been linked to this disease. And both of these genes mutations, they're mostly autosomal dominant mutations. Occasionally, ABCC8 can be autosomal recessive as well, but these mutations can result in neonatal diabetes, permanent neonatal diabetes, or PNDM. Also the DEND syndrome, which is developmental abnormalities, epilepsy, and neonatal diabetes syndromes. So both of these could be produced by these two genetic mutations on the potassium ATP channels. Also, there's another gene called TRMT10A, which results in short stature, microcephaly, intellectual disability, and diabetes with resistant epilepsy, and epileptic encephalopathies sometimes. There's another gene that's being looked at, ZFP57, but not a lot of data is available yet. Environmental factors. Chronic inflammation is the known environmental factors. Also, children being exposed to harmful chemicals or maternal gestational diabetes in utero perhaps exposes the developing brain and predisposes them to having epileptic seizures at a later stage in life. Obesity is a variable risk factor. It can worsen both epilepsy and diabetes. Metabolic changes that are brought about by obesity can also affect the brain function, also impact glycemic control. Physical inactivity and sedentary lifestyles can worsen both. The diet can impact both diabetes and epilepsy. Diets heavy in fat and sugars have been linked to a higher risk of diabetes. On the other hand, a ketogenic diet, which is used to treat resistant, particularly focal resistant epilepsies, rich in fats, low in carbohydrates, and with moderate proteins, have been shown to improve seizure frequency by inducing ketosis and monoamine systems. Chronic stress is a risk factor for both diabetes and epilepsy. There are certain comorbid conditions which can affect both. As I said, depression and anxiety seems to be prevalent in both these diseases. And also you must keep in mind that one worsens the other. Epilepsy, diabetes, psychological disturbances, all of them is like a vicious cycle, so they worsen each other. Keep in mind certain antipsychotics can worsen diabetic control, like olanzapine. There are certain antipsychotics that can lower seizure threshold, risperidone for instance. Sometimes even olanzapine has been linked to lowering seizure threshold. So drug-drug interaction is also important. What about the therapeutic implications? Okay, another 10 minutes. Good. So diabetes management can be more challenging for patients with epilepsy. As I said, epileptic seizures can impact blood glucose levels. There are release of stress hormones that can result in hyperglycemia secondary to insulin resistance. Also, prolonged post-ictal states can cause hypoglycemia because of greater utilization of glucose during the seizure. Also, antidiabetic medications need to be kept in mind because some of them have an interaction with AEDs and can reduce the serum levels of these AEDs, can cause less than ideal seizure control. Also, you need to keep in mind the AEDs that you're using because certain drugs like carbamazepine and phenytoin, which induce the hepatic enzyme P450 system, can reduce certain oral hypoglycemic agents like sulfonylureas, therefore worsening diabetic management in some of these patients. Also, epilepsy and diabetes causes cognitive deficits and behavioral problems. They impact executive function, memory impairment, and that results in medication adherence becoming more and more difficult. Also, diabetes-related self-care activities become a little more difficult to adjust to, including monitoring blood glucose levels, following dietary recommendations and prescriptions. If there are psychiatric conditions, as I was mentioning, epilepsy, diabetes, and psychiatric comorbidities can impact mood and motivation and make diabetes management more difficult. Does seizures affect blood glucose levels? The obvious answer is yes, because a seizure can release stress chemicals, as I said, cortisol and adrenaline, and that can spike after a seizure, resulting in impaired glucose absorption by peripheral tissues and release of more glucose from the liver, gluconeogenesis, therefore causing hyperglycemia. Prolonged seizures can result in hypoglycemia as well, and that can result in seizures, so it could set about a vicious cycle. Certain antidiabetic medications you have to monitor very carefully, and perhaps continuous glucose monitoring could be a way forward because you could identify these changes quickly and intervene if required to prevent a permanent brain injury. Keep in mind the antidiabetic drugs that you're using because of their potential to affect seizure management and also the interactions with AEDs. Insulin is relatively safe. It does not react with AEDs but can sometimes cause inadvertent hypoglycemia precipitating a seizure. Metformin, as I mentioned, modifies oxidative stress and mitochondrial function, therefore it has perhaps a neuroprotective effect on epileptics in diabetes. Sulfonylureas are also reasonably safe, but the two things that we need to consider is the patient on carbamazepine because hepatic enzyme induction can happen and sulfonylurea levels may drop. Also, there's a risk of hypoglycemia that can precipitate a seizure. GLP-1 RAs and SGLT2s are the newer drugs, and these are very safe, both in terms of glycemic management and also they have no interaction with AEDs. I look at AEDs in diabetics, mostly for seizures, but also for painful diabetic neuropathy. Again, if you're interested, you could go through this wonderful article by Asadi Puya and Michael Sperling, published in the Oxford Textbook of Neurology, looking at anti-seizure medication in patients with diabetes. So you have to select the appropriate AED, because in diabetics and epileptics, if they are concurrently present, there are multiple comorbidities, and they may be taking a lot of medication. Also, some of these anti-epileptic drugs may worsen diabetes, can worsen obesity, can worsen psychiatric comorbidities, therefore you need to be careful there as well. And as I said, drug interactions are important to keep in mind, like carbamazepine and phenytoin, which can induce the hepatic enzyme system, and reduce the concentration of certain OHAs like sulfonylureas. Levetiracetam is a very safe drug. It has no interaction with OHAs because it has a different mechanism of action, the SV2A, synaptic vesicle 2A antagonist. So this doesn't have, also brivaracetam, does not have an effect on diabetics, on OHAs, and has been found to be useful in neuropathic diabetic pain. Lamotrigine also does not have any problems with regard to diabetes. It's an effective drug in generalized seizures, excepting hypersensitivity reactions, of course, and is useful again in peripheral diabetic neuropathy. Vigabatrin can cause weight gain in both adults and in pediatric patients, and can also worsen peripheral neuropathy in diabetics. So this is a drug best avoided. Zonisamide is useful for both generalized and focal seizures, but the interesting point is that it can result in weight loss, which could be useful in some of the diabetic patients. Perampanel is a safe drug as well, mostly safe drug, but there are anecdotal reports of weight gain in diabetic patients, so do exercise a bit of caution. Acetazolamide is best avoided because they are known to cause metabolic acidosis in diabetic patients. Gabapentin and pregabalin are suboptimal for seizure control, but are useful for the treatment of diabetic peripheral neuropathy. Just keep in mind that some of them could increase appetite and could worsen the weight, and that could result in loss of glycemic control or glycemic index. So just keep in mind, while you're treating peripheral diabetic neuropathy with either gabapentin or pregabalin, weight gain could be a problem in diabetics. Topiramate is again a very useful drug, both for control of seizures, and it does not have any impact on the diabetic management, diabetic control. Useful for diabetic neuropathy as well. What about the older drugs? Sodium valproate, again an absolute no-no. Increases weight, adipocytokine homeostasis is altered, insulin resistance occurs, and NFLD occurs. So this is not a good drug. As is phenytoin, again not a good drug. It impairs insulin resistance, causes insulin insensitivity, induces cytochrome P450 system, and reduces OHA concentrations in some, worsens hyperglycemia, so best avoided. Carbamazepine is usually useful, but if you're using in children, sometimes it can cause weight gain, so be careful in young children with diabetes and type 1 diabetics. And also keep in mind that if you're using with sulfonylureas, you need to look at the glycemic control again and again. So what medicine would we choose? Generalized epilepsies, lamotrigine, levetiracetam, topiramate, and zonisamide. These would be my drugs of choice. For focal epilepsies, levetiracetam, carbamazepine, followed by topiramate and zonisamide. If you have concurrent neuropathy, pregabalin, lamotrigine, gabapentin, carbamazepine, topiramate, all of these could be useful. But as I said, if you're using carbamazepine, pregabalin, and gabapentin, be careful of weight gain. And on the other hand, topiramate and zonisamide could cause weight loss, so this is very useful. A long list of drugs have all been tried, from felbamate, gabapentin, lamotrigine, topiramate, tiagabin, levetiracetam, have all oxcarbazepine, even phenytoin and carbamazepine. All of these have been tried in peripheral diabetic neuropathy and found to be useful. You just need to be careful that some of these drugs may cause weight gain or may worsen glycemic control and are best avoided. So I think I've got maybe 2-3 minutes, so we'll just quickly rush through epilepsy in special situations. Firstly, hyperosmolar hypoglycemic state in epilepsy. Now this is a condition, HHS is a condition where there's severe hyperglycemia, hyperosmolarity, dehydration in the absence of ketosis. Epileptic seizures are commoner in patients with HHS as compared to DKA. Perhaps ketosis is protective in DKA, and 25% of HHS patients present with epileptic seizures. Several seizure types can be seen, most commonly focal motor seizures, sometimes focal seizures epilepticus, generalized seizures, focal sensory seizures with aura, and sometimes even occipital seizures. What are the causes? Decreased GABA, because HHS disrupts the Krebs cycle, results in utilization of GABA, something called the GABA shunt. The GABA levels drop. There's also a reversible blood-brain barrier permeability, hyperosmolar state, dehydration, and seizures. Why focal seizures in HHS? We don't know the answer, but perhaps vasculopathy, vascular insufficiency affects one side of the brain more in patients with HHS, resulting in focal motor seizures. Diabetic ketoacidosis seizures are less common, rare in fact, because perhaps ketosis is protective. If the patient has HHS diagnosed and you have hyperglycemia more than 450 milligram per DL and you're having seizures, that is the most important cause. Anti-epileptic drugs will be pretty much useless. You will have to hydrate the patient, administer insulin, and that will cause the seizures to stop. But remember, you will take some time to hydrate the patient and bring the sugar levels down. So you'll take about 15-30 minutes, sometimes 45 minutes to an hour. So you'll have to protect the airway and ensure circulation in an ICU setup if the patient is having a seizure. But don't get too disheartened if the seizures continue. Don't be too enthusiastic and put the patient on benzodiazepines or ketamine or thiopentone and so on, anesthetic agents. Seizures will usually stop when it's less than 200 milligram per DL. Type 1 diabetes, there is several factors that are responsible for type 1 diabetes and epilepsy to coexist. I'll quickly rush through some of these slides. The first study that I mentioned was the prevalence study in the United Kingdom, which showed type 1 diabetes and epilepsy had a 3 times greater risk factor to produce epilepsy than in the normal healthy controls. Children with diabetes type 1 are 6 times more likely to develop epilepsy as compared to the healthy population. The underlying etiologies include shared genetic factors, local brain damage, and autoimmune risk factors. Of course, I was discussing the genes KGN11, ABCC8 on the potassium ATP channels on the pancreatic beta cells are affected. That produces permanent neonatal diabetes mellitus and the DEND syndrome. Also, there are newer genes that are being looked at. Autoimmunity is important because anti-GAD65 antibodies are responsible for both type 1 diabetes and epilepsy. It's an interesting article by Christian B, and if you can get a chance to read this, do so, because GAD65 antibodies are found positive in almost 60 to 70% patients with type 1 diabetes and are also responsible for seizures, stiff person syndrome, cerebral ataxia, thyroiditis, chronic anemia, and vitiligo. 30 more seconds, chairpersons. Local brain damage has been found. Type 1 diabetics who have epilepsy have mesial temporal lobe sclerosis, and there are cerebral infarcts that can precipitate seizures as well. There are certain clinical things that we need to keep in mind. Seizures are more commonly generalized in patients with type 1 diabetes, occasionally focal status epilepticus. Cognitive impairment can occur in these patients. Neuroglycopenic cognitive deterioration can also result in impaired learning abilities. Therapeutic considerations, AEDs remain much the same, excepting be careful if you're using carbamazepine, because that can precipitate hyperglycemia in children. Ketogenic diets are very useful. And the exact mechanism is perhaps by modulation of biogenic monoamines and neurotransmitters, increasing GABA. But be careful in type 1 diabetics, because you are giving the chance of ketosis in a patient who's at risk for diabetic ketoacidosis. While you want to control seizures, you do not want to precipitate ketoacidosis. For KCNJ11 and ABCC8, you might require either insulin or sulfonylureas, because like glibenclamide, which blocks SUR1 and 2 receptors. For the DEND syndrome, you need higher doses of sulfonylureas and perhaps insulin. And if you have underlying autoimmunity like GAD, think of immunotherapy with IV methylprednisolone, IVIG, plasma exchange, pulse cyclophosphamide, and in some cases, mycophenolate may be also helpful. Thank you very much, ladies and gentlemen. And thank you, chairpersons, for your indulgence with the time.
Thank you, Dr. Arindam, for such a nice presentation. Both epilepsy and diabetes are common disorders. Initially, it was not thought that there is some association, at least we never discussed about it. But there is evidence, evolving evidence, as Arindam has so rightly pointed out. Several lines of evidence suggest that there is a relationship, probably a bidirectional relationship between the two. And he has elaborated so well. He has mentioned about autoimmune epilepsy also, which may occur in diabetics. And there is a dilemma in treatment. We have to give steroids for that, which may make worsen the diabetic control. My co-chair.
Yes, thank you, Arindam, for an excellent presentation. And from a neurosurgical perspective, sometimes these seizure patients do come to emergency. So it's very important to keep the medical history in mind and to rule out the metabolic causes of seizures. So
Absolutely.
This is very important, to rule out electrolyte abnormalities, the blood sugar level. So thank you. And any question?
Yes, yes, Bishara.
For these patients?
No. Peripheral neuropathies are of two types. One, of course, demyelination. The other is very axonal. So if there is nerve injury and there is axonal involvement, for some time you might end up perhaps giving some degree of neurostimulation, but not for a generalized neuropathy like that of diabetes. Neurostimulation is not really going to help a lot. I always believe that trying to prevent a neuropathy from happening would be more important than administering neurostimulation or even some of the anti-epileptic drugs that I've just mentioned.
So at times you are helpless. Most of the medicines, then what
Yes,
go to for next?
yes. Also, I think it's also important to take a very good history, because a lot of these patients will come to you with paresthesias, with pain, burning sensation. These are reasonably treatable. But the things that do not get easily managed is A, numbness. If you have a loss of sensation, that is not remediable. And the other part is if you have large fiber neuropathy, that results in unsteadiness, an ataxic gait. Sensory neuropathy, large fiber sensory, that makes it very difficult for the patient's mobility. But another history is important. A lot of this pain actually happens at the night. And sometimes we overlook the obvious risk factors of restless leg syndrome. They will not always tell you I have they won't give you the textbook definition of an uncomfortable feeling at rest or at night. You will have to keep probing. Does it happen when you are resting? Does it happen when you just go down to sleep? Maybe 10, 15 minutes later, do you find your legs cramping up and you have to move your legs? They will tell you, I have to ask my husband or my wife to sit on my leg to offer relief. Then you think of possibility of restless leg syndrome and perhaps use either pramipexole, ropinirole, which is available with us, or a rotigotine patch could also be useful. So a proper history would help in some cases.
Thank you.
Bishmay, a comment. He has rightly pointed out, once the nerves are gone, if there is axonal, nothing will help. Negative symptoms such as lack of sensation, numbness, or ataxia, they are not helped by anything. And positive symptoms we can treat with, but there may be some placebo effect to peripheral nerve stimulation, which may be of some benefit to the patient.
Dr. Arindam, first of
Yes.
all, I must thank you for your very illuminative lecture.
Thank you,
Number
sir.
one. Number two, in your clinical practice, how many cases you have got with epileptic seizures and diabetes mellitus? And how do you tackle it?
It's not uncommon. This is actually, we tend to neglect, super specialists, I believe, tend to neglect a lot of comorbid illnesses. So if you have epilepsy, as neurologists, we are so concerned about treating the epilepsy part of it that we do not really think about the hypertension, the diabetes, and things like that. We just say, okay, go to the internist or go to the endocrinologist and get that rectified. It is not uncommon, particularly in elderly populations. In younger people, it's not very common. If you remember the first study that I showed you, people above 64 years, 10% of epileptics have diabetes. But below the age of 64 years, it's about 2 to 3%. So it's not common in the younger populations, but elderly populations, perhaps because long-standing diabetes in these patients cause some degree of vascular lesions in the brain, makes the blood-brain barrier also perhaps a little more permeable. So all of these conditions could precipitate seizures. They are more susceptible to fluctuations in their glycemic control, a drop, sudden hypoglycemia at night. So epilepsy is more common, seizures are more common in the elderly population. This is what I find in my practice as well, not so much in the younger people, unless there's a shared autoimmune etiology like GAD65, as I was mentioning.
And how do you tackle? How do you tackle initially?
Tackle the epilepsy. See, that's the interesting part. So I concentrate on the primary complaint which is the patient has come to me. If it's a seizure, I'm sure there's already been somebody who's looking at the diabetic part of the things by the time he or she has come to me. So I try and concentrate on the seizures. I do not use epileptic drugs, anti-epileptic drugs that I just mentioned that can worsen glycemic index, like sodium valproate, like phenytoin. Despite some patients who may not be of the certain socioeconomic strata which you can afford more expensive drugs, they would prefer to use phenytoin, for instance. In the government hospitals, people do not have enough money. They would prefer to use phenytoin, but it is important to tell them that if you use phenytoin, your sugars may get worsened. If you're using carbamazepine, for instance, or oxcarbazepine, which are hepatic enzyme inducers, check if the patient is on sulfonylureas. Try and ask or speak to your diabetologist if we can use some other drugs. Today, with the new advent of SGLT2 inhibitors and all of the new drugs that have come by, the interactions between AEDs and oral hypoglycemic agents have really come down. So it's not really a problem. But as I said, drug-drug interaction is important. For me, seizure control is important. But also we must keep in mind that hyperglycemia should not be a cause for seizures. It should not be so unchecked that the patient ends up in the hospital with an HHS or a DKA, rarely a DKA, but more often HHS with a seizure. So that's what we try and prevent.
Thank you.
Any other comment or queries? If no, I declare the session closed. Thanks.
Thank you, chairpersons and the organizers.
Thank you, Speaker, sir, for such an enriching session. I would like to request our chairperson and founder member, Dr. S.K. Somani, to kindly felicitate Dr. Niloy Vishwas. Thank you, chairpersons. Thank you, Speaker, sir.